So insert natin yung gamot na calcium channel blockers, or they are also known as CCBs. So again, yung MOA nila, they block the L type. Okay, they block the L type calcium ion channel. Okay, question. Whenever a drug blocks calcium ion channel, o tingnan sa figure, do you think the trigger calcium can enter the cell, the arterial cell, yes or no? So it will not enter the cell. Very good. Okay. O ngayon, pag walang papasok na trigger calcium, okay, kapag walang papasok na trigger calcium, walang lalabas na calcium stores from the sarcoplasmic reticulum. Okay, kasi walang pang trigger calcium. Okay, so mananatiling hidden, okay, it will remain hidden yung mga calcium ion stores sa sarcoplasmic reticulum. Okay? Therefore, kung they are remained hidden here, walang calcium, okay, available now in the cytoplasm. Walang calcium ion available in the cytoplasm. Therefore, walang re-react kay calmodulin, walang complex, no? Walang complex na calcium calmodulin. Okay? So kung wala yan, walang activation of the enzyme kinase. Okay? The myosin light chain kinase. So walang mangyayari therefore na phosphorylation. Kung walang mangyari na phosphorylation, it will remain as MLC, myosin light chain. Relaxation, ultimately, yung expected effect, no, ng mga calcium channel blockers. Okay, relaxation of arteries. Okay, so dilation yan, ha? Dilation of arteries or relaxation. So that's the effect of, or the mechanism of action of calcium channel blockers. Now, talking about calcium channel blockers, we can classify them based on chemistry, based on their structure. Okay, so natay tulo ka specific classification. We have the phenylalkylamines, okay, and then we have the benzothiazepines. Now, these two, okay, classification, they are collectively known as non-dihydropyridines. Okay, non-dihydropyridines. Okay, that's the meaning of DHP. And then the third group, okay, based on chemical structure ng mga CCBs, we have the dihydropyridines. Okay? Palatandaan under dihydropyridines ng mga calcium channel blockers, those ending in dipins. Dipins, mga DHP yan. Mga dihydropyridine calcium channel blockers. Whereas, yung non-dihydropyridine, sila yung not ending in dipin. So, dalawa lang yan, verapamil and diltiazem. Okay, so this is the classification based on chemical structure. Now, moving forward, so again, yung non-dihydropyridine and dihydropyridine, that is the classification based on chemical structure, based on chemistry. Now, from that, we can classify further the CCBs based on the site of action. Okay, based on their site of action. Okay, so we have, halimbawa, for non-dihydropyridines, in terms of site of action, meron silang cardiac effect. Okay, meaning there are non-dihydropyridines that target the heart, cardio. Okay, targets the heart aside from their vaso or arterial effect, no? Aside from their vasodilating effect sa arteries. Okay? Kaya nakalagay cardioselective. Okay? So, we have those that targets the heart. Okay? Particularly, that non-dihydropyridine CCBs that targets the heart is the verapamil. Okay? Verapamil, take note, it is said to be cardio-selective. Okay, cardio-selective. Kaya nakalagay, greatest depressant effect niya is on the heart. Okay, on the heart, cardiac. Diba? Cardiac. Okay? So, I repeat, yung calcium ion channel blocking effect ng verapamil is focusing on the heart. Cardio-selective siya. Whereas, ang diltiazem, intermediate. Intermediate yung action niya as calcium channel blocker. Okay, it targets both, no? Both the arteries and then the heart. Kaya 50-50 intermediate. Meron siyang ability to dilate, okay? The card, no? It can stimulate. Not stimulate, depress pala. It can depress the cardiac, okay, or the heart, or it can dilate the arteries. Yan yung ibig sabihin ng intermediate action. Both vasoselective, cardioselective, diltiazem. Now, whereas kapag naman mga lipins, site of action nila, arteries only. Arteries only. Kasi vaso, vessels lang. So, what we are talking about here na vessel, di ba, is the arteries. Kasi doon makikita yung calcium channel. Okay, calcium channel. Okay, so specifically, vasoselective, mga dipins. Okay, mga dipins. Okay. Now, regarding nifedipine, this is an ultra-short acting, okay, ultra-short acting na dipine, which is used for severe or emergency type of hypertension, severe hypertension, emergency management, no, for severe hypertension. Okay, that's the important thing that you have to remember with nifedipine. Right? So far, we have discussed the two classification ng CCBs based on chemistry, based on chemical structure, and also based on the site of action. Mayroong cardioselective, vasoselective, merong vasoselective lang. Now, we can classify CCBs also based on the duration of action. Based on the duration of action. Okay? So, when you say duration of action, ito yung classification sa CCBs kung gaano sila katagal, no, magbigay ng response or action sa katawan. Okay? How long yung effect nila, okay, sa body once administered. So, we have CCBs classified as short-acting, intrinsically short-acting. Take note. Under this are all dihydropyridines. And what are those again? We have verapamil and diltiazem. Okay? Non-dihydropyridines. Short-acting sila. All. Okay? All and non-DHPs. Okay? Also, we also have DHPs, okay, na short-acting, okay, except yung LAL. Okay, except LAL. I repeat, dihydropyridines din na mga calcium channel blockers, short-acting din sila except LAL. Kasi, itong tatlo, itong LAL, lercanidipine, amlodipine, lascidipine, long-acting sila. Okay, long-acting sila. And then we also have modified long-acting. Modified long-acting CCBs. Actually, under modified long-acting, mga short-acting din ito under this. Mga short-acting example ng CCBs. Okay, pero yung dosage form nila, binago lang. Okay, binago lang yung dosage form nila. For example, Halimbawa, available in the market, we have Verapamil, SR. Verapamil, SR. Si Verapamil, kung titingnan natin, di ba, that is a non-dihydropyridine. Kasi not ending in dipines. Not ending in dipines, automatic, non-dihydropyridine. Okay, and in general, ang mga non-dihydropyridines classified as short-acting CCBs. But since its dosage form uh, has been changed already, okay, or reformulated already into a modified release 1 or sustained release na, okay, we expect natatagal, no, sa katawan yung effect ng Verapamil SR. Kasi SR means sustained release yung drug. Tatagal siya, no? Longer yung duration of action niya. Okay, that's why considered na siya ngayon as long-acting modified. Okay, long-acting but modified, ha? Okay, so done with the classifications of CCBs. Okay. Now, for the clinical uses, recall that calcium channel blockers, they are considered as first line. Okay, antihypertensives, di ba? They are considered as first line antihypertensives. This was mentioned, di ba, during our discussion sa thiazides. Okay. Now, we also have calcium channel blockers that are very useful for angina. Okay, so madiscuss nato ni nga effect ng calcium channel blockers when we discuss anti-anginals. Okay, so that will be discussed on the next, on the following, okay, meeting. And then we also have CCBs, especially those cardio-selective, okay, na CCB, okay, cardio-selective CCBs na ginagamit for the management of supraventricular tachycardia. Kasi when you try to analyze tachycardia, ventricles, it has something to do with the heart. It has something to do with the heart. So yung kailangan dyan is a CCB na may ability to target the heart. Okay? So specifically, that would be Verapamil. Okay, so pwede yan gamitin for supraventricular tachycardia. Kasi nga, Verapamil, di ba, is a cardio-selective CCB. A cardio-selective. And then for the other miscellaneous na clinical uses, so just take note of this. Meron tayong CCBs na ginagamit din for Raynaud's syndrome, okay, for migraine, for stroke, okay? Then preterm labor, and then for nimodipine, okay? This is used for hemorrhagic stroke, okay? Hemorrhagic stroke. Okay, so these are just additional uses of CCBs. Okay, but with regards to our topic, since we're talking about antihypertensive drugs, so you can already rationalize why CCBs, diba, is considered an antihypertensive because of its mechanism of action. So these are good to know facts that is also important for you to know. Okay, next. For the adverse effects naman, the most common na extra cardiac effect, okay, yung effect na hindi related sa puso, okay, is constipation. Okay, this is the most common nga extra cardiac effect. So not related sa puso na activity or action ng CCBs is yung constipation. So very common side effect yan outside the heart, constipation. And then another adverse effects, we have pretibial edema, nausea and vomiting, flushing, fatigue, confusion, and also allergic reaction. Okay? So pag tinanong, most common nga side effect naman ng CCBs in relation to heart, Oh, that would be hypotensive effect, no? Hypotension. Kasi nga 'di ba nagpapababa siya ng BP, okay, upon dilating the vessels, upon depressing, no, the heart. So hypotensive. Yan naman yung common for cardiac related side effects. Okay, ito naman for these slides, these are also adverse effects but for specific na mga CCBs. Okay, halimbawa with verapamil, take note, it has adverse effects of the following: bradycardia, congestive heart failure, the atrioventricular, okay, atrioventricular block, okay. Also, kindly add sinus node depression also. Sinus node depression. Now, all of this listed, these are cardiac related na mga adverse effects. Kasi nga, basically, when we go back to the mechanism of action ng verapamil, di ba, that is a cardio-selective na drug. So, we expect na yung side effect niya, okay, in relation to its MOA would be cardiac-related din, okay, yung adverse effect. And then for Bepredil naman, torsades de Pointes. Okay, so that's the side effect of Bepredil, which will be discussed sa arrhythmia. Okay, we will discuss that condition, torsades de Pointes, sa arrhythmia. Okay, so utang ko muna yan. Okay, so that would be the end of vasodilators. Okay. So let's proceed on the last classification of antihypertensives. We have the angiotensin blockers. Okay, or these are the inhibitors of angiotensin. Okay, inhibitors of angiotensin. Now, basically, when we talk of angiotensin blockers, angiotensin antagonists, these are the agents that targets the RAAS. Okay, naalala ba yung RAAS? Particularly, they target angiotensin 2. Okay, the angiotensin 2. Okay, recall na yung activation of RAAS, once it is activated, once the renin is released, that induces formation of angiotensin 2 ultimately. Kapag nabuo yung angiotensin 2, what is the ultimate effect? 'Di ba? Sobrang dami, but that leads all to increase blood pressure. Okay, kapag andyan na si angiotensin 2. Ultimately, effects would lead to increased BP. Specifically with angiotensin 2, okay, angiotensin 2, this is said to be an arterial vasoconstrictor. Diba? It is an arterial vasoconstrictor. Okay? Kaya it is able to constrict arteries. Okay? Constricted yung arteries. Siyempre, kapag constricted yung arteries, tumataas yung arterial pressure. Kaya, ultimately, taas BP pa rin. And then, formation also of angiotensin 2, di ba, that causes fluid retention. Okay, fluid retention kasi nabubuo yung aldosterone. Okay, that is because of the formation of aldosterone, may fluid retention, may sodium ion retention. And again, with fluid retention, taas yung volume, ultimately taas BP. Okay? Kaya we have certain drugs, no, that are used to block angiotensin. Okay, meron tayong mga gamot na able to block angiotensin. Kaya meron tayong angiotensin antagonist, angiotensin inhibitors. They target angiotensin. Kaya mapipigilan yung vasoconstriction. Okay? 'Di ba? So kapag pigil yung arteriolar vasoconstriction, arteries will be relaxed. Okay, arteries will be relaxed. Now question, ano ba yung related sa arteries? Okay, is it the preload or the afterload? That is the preload or afterload. Diba? It is the afterload. Okay? Kaya may nakalagay diyan, baba yung SVR, no? Baba yung SVR, 'di ba? SVR is also known as peripheral vascular resistance. Okay? Reduce yung afterload. Reduce afterload. Also, upon blockade of angiotensin 2, when a drug is able to block angiotensin 2, syempre mapipigilan itong fluid retention. Diba? Mapipigilan din yung fluid retention, kaya bababa ultimately yung blood volume. Okay? Bababa ultimately yung blood volume. Okay? So yan definitely yung ginagawa ng angiotensin blockers generally. They reduce, they lower the blood pressure via reducing afterload and also the blood volume. Okay. Now, regarding the agents under angiotensin antagonists, we have two classes. Okay, two general classes under angiotensin antagonists. We have the ACE inhibitors. Okay, ACE inhibitors, and we also have what we call the ARBs. ARBs, that is angiotensin receptor blocker. Okay, or angiotensin 2 receptor blocker. Okay, angiotensin 2 receptor blocker. Now, these two classes, please take note na different yung MOA nila. Okay, they have different mechanism of action. Specific mechanism of action, magkaiba po. Okay? But, yung similarity nila is that they specifically targets RAAS. Okay, similar sila because they both targets RAAS. So, dyan sila nagkakasundo. Okay? So, since yung action ng dalawa, it has something to do with the RAAS pathway, it would be good, it would be beneficial to everyone na ato ang i-recall ang RAAS pathway. Okay, madalian lang na pag-recall. I know you are already familiar with the RAAS pathway. Okay, so I'll repeat, bago ulit yung drugs na ARBs, bago ulit yung drug na ACE inhibitors, yung normal or physiological pathway muna sa RAAS. Okay? So please, never mind muna yung mga drugs. Okay, never mind muna yung mga drugs. Okay, yung pathway lang sa ta mag-focus. Okay, so simulan natin sa left side na pathway. Okay, itong nasa left, ito yung RAAS, di ba? RAAS pathway. So, asa magsugod ang RAAS, di ba? When renin is released. Okay? When there are triggers that releases renin, RAAS will be activated. So, once renin is released from the kidney, that readily acts, di ba, to the angiotensinogen producing angiotensin 1. Okay? Take note, yung angiotensin 1, that is still inactive. Inactive, wala pa siyang physiological effect. Naalala? Pero si angiotensin 1, kahit wala siyang physiological effect, kailangan natin siya para mabuo yung active form niya. And what is the active form of angiotensin 1? That is angiotensin 2. And take note, there is an enzyme responsible for the conversion of angiotensin 1 to angiotensin 2. And the enzyme that is responsible for the conversion to happen is the ACE. Kaya may nakalagay dyan, yellow box, ACE, angiotensin converting enzyme. Okay? Or this is also known as kinase 2. O anong organ dominantly nasisekrete yung ACE? Is it letter A, lungs, or letter B, kidney? Okay, very good. It's lungs. Okay, so again, very important yung role ng ACE, okay, para mabuo yung angiotensin 2. Kung wala si ACE, listen, if wala si ACE, wala si angiotensin 2. Okay? Then, with regards to angiotensin 2, pag meron na tayong angiotensin 2, excuse me, it will then actively bind to its receptor. Excuse me. Okay, then the receptor of angiotensin 2 particularly, is known as angiotensin 2 type 1 receptor. Okay? Yan po yung pangalan ng receptor kung saan kumakabit yung angiotensin 2. I repeat, yung angiotensin 2 will then actively bind to its receptor. And that is known as angiotensin 2 type 1 receptor. And activation of that receptor, kapag na-activate, okay, na-activate, na-stimulate yung angiotensin 2 type 1 receptor, the following effects will be resulted. Okay? Ayan. So there would be vasoconstriction, aldosterone secretion, then ultimately, 'di ba, taas BP kapag raas. Kapag raas, ultimately taas BP. Okay? So muna yung dumduman, basta gani mabuo na si angiotensin 2. Whenever angiotensin 2 is already synthesized, produced, yung destiny niya talaga is to bind to the AT1 receptor. And end result, taas BP. End result, taas BP. Okay? Now, let's give emphasis to this ACE inhibitor. Okay? So, balikan natin yung, not inhibitor, yung enzyme pala nga ACE. Okay? Rather. Okay, I repeat, balikan natin yung enzyme na ACE. Okay? Or this is also known as kinase. Now, aside from importante siya for RAAS pathway, diba, importante siya for RAAS pathway para mabuo yung angiotensin 2. Aside from that importance, this is also very essential for the degradation of bradykinin. Okay? Degradation of bradykinin. That's the other role or action of ACE once available in the body. Na de-degrade, na i-inactivate yung tinatawag na bradykinin. And that is an endogenous substance. Okay? I need to introduce this. I need to introduce this pathway on the right side. Okay? Kasi later on, pagpasok ng drugs, halimbawa, a drug is able to inhibit ACE. Diba? Siyempre, matatarget niya yung RAAS. Matatarget niya yung RAAS. But aside from that, that drug that is able to target ACE enzyme will also affect this pathway on the right side. Okay, that's why I need to introduce also this pathway on the right side. And you have to know this. Okay, so I repeat, ACE is also essential for the degradation, inactivation of what we call bradykinin. Kaya nga 'di ba ang other name niya is kinase, kinin, and then ACE, meaning an enzyme that degrades or inactivates a kinin. Okay? An enzyme that is able to catalyze or degrade kinin, specifically bradykinin. Okay? Kaya tinawag siyang kinase 2. Okay? Now, ano ba yung bradykinin? Okay, so highlight natin. What is this bradykinin? Bradykinin, that is formed from its precursor protein, kininogen. Diba? Yung nasa pathway. Nabubuo siya from its precursor, from its raw material, kininogen, upon being reacted by the enzyme kallikrein. Now, giving focus to bradykinin. This was actually mentioned sa recorded lecture video on the receptors, if you can still remember. This is an example of endogenous compound. Particularly, this is an otacoid. Naalala yung otacoid na mnemonics? Di ba, BESH? Otacoids, BESH. Yung B dyan, di ba, is bradykinin. Okay? So, that is an otacoid, a local hormone. Now, ano ba yung role niya in the body? Please take note that bradykinin is considered a potent, a powerful vasodilator. Okay, this is a powerful, potent endogenous vasodilator. Okay, so please take note of that. Bradykinin It is a potent vasodilator. Now, bakit siya powerful vasodilator? Take note, the reason bakit powerful vasodilator yung bradykinin, it is because, number one, yung bradykinin itself, that is already a vasodilator. The same thing with nitric oxide, di ba? When I say nitric oxide, isa siyang potent, isa na siyang vasodilator. So parang ganun din si bradykinin. Isa na siyang vasodilator. Kumbaga, yan na yung direct action niya. So number one, okay, that is the reason. It is because of its direct action. It is because of its direct action as a vasodilator. Also, yung direct action niya, relative to its direct action na vasodilator, that is being influenced by the action niya or capability to stimulate nitric oxide. So, yan yung dahilan. Bakit siya merong direct action as vasodilator? Kasi able siya to release nitric oxide. And recall, kapag may nitric oxide, kapag may release of nitric oxide, what do we expect? Vasodilation. Diba? Vasodilation. Now, aside from that reason, okay, bakit powerful vasodilator si bradykinin? Number two, yung bradykinin also induces prostaglandin synthesis. Okay? It induces prostaglandin synthesis. So, yan yung second nga reason bakit powerful vasodilating si bradykinin. Okay? Kumbaga, it increases the prostaglandin synthesis. Specifically, yung mga prostaglandins na mayroong vasodilating activity. Di ba? Meron tayong mga na-mention sa previous lectures na may mga prostaglandins with vasodilating action. Halimbawa, ng prostaglandin with vasodilating action is the prostacyclin. Okay, the prostacyclin, the PGI2. Okay, this is a determinant, okay, ng vasodilating activity sa katawan. Presence of prostacyclin or PGI2. And also those PGE series. Okay, the prostaglandin E series. May it be PGE1, PGE2, prostaglandin E series, meron din yang vasodilating activity na prostaglandin. Yung mnemonics ko dito, para matandaan ko yung mga prostaglandin na may vasodilating activity, is DIE. Okay? D-I-E. Okay? DIE. Dilators, yung prostaglandin I, yung PGI2, ay PG pala, PG. Ayan. And then yung mga E-series. Okay, yung mga E-series. Okay, dilators, yung prostaglandin I2, okay, or prostacyclin, then the E-series. Okay, so please take note, mechanism of action ng bradykinin, okay, as vasodilating substance is number one, direct action na niya as vasodilator yan. Okay? Particularly, that is being influenced by its ability to release nitric oxide. And pangalawa, it is able to induce those prostaglandin synthesis, no, na may vasodilating effect. Okay? It is able to induce the release of vasodilating prostaglandins. Thus, in general, we can really say that bradykinin is a potent, a powerful, no, endogenous vasodilator. Okay? Now, tingnan natin sa pathway, no? With bradykinin, merong, ayan, vasodilation, di ba? You try to highlight the arrow from bradykinin towards the effect vasodilation. Okay? Kapag may bradykinin available, vasodilation yung effect. Again, kapag merong bradykinin, may vasodilation that we expect. Kaya bababa, no, ang BP, bababa yung BP. Okay? So yan yung importance ni bradykinin dito. Okay, however, kung babalikan natin, when RAAS is activated, okay, when this pathway on the left is activated, okay, yung nasa left nga pathway, kapag activated siya, di ba, syempre, merong ACE. Kapag activated yung RAAS, syempre may ACE. May enzyme, angiotensin converting enzyme. What did I tell you sa activity ni ACE towards bradykinin? Does it degrade or stimulate bradykinin? Does it degrade or stimulate bradykinin? Okay, very good. Okay, take note. Yes, si ACE, ginastimulate niya ang RAAS, but yung ginagawa niya on the other pathway, dinedegrade niya si bradykinin. Okay, inactivate niya si bradykinin. Okay, therefore, if inactivated degraded, what will happen to the level of bradykinin? Baba or taas? Baba or taas? Very good. So with ACE enzyme, okay, yung effect niya kay bradykinin, bababa yung level ni bradykinin. Therefore, kapag baba si bradykinin, may vasodilation or wala? May vasodilation kaya wala. Very good. Okay, walang vasodilation. Kaya, mas ma-favor ngayon yung nasa left side na pathway. Okay? Mas ma-favor yung nasa left side na pathway kung saan ma-favor yung increased BP. No? Increased BP. Dahil nga sa activation ng RAAS pathway. Dahil sa activation ng RAAS pathway. That is why, kailangan natin ng mga gamot that really targets RAAS, no? And we have that, no, available in the market, those drugs that targets the RAAS pathway. It needs to be inhibited kapag hindi na siya good sa katawan, hindi na pang compensatory mechanism yung ginagawa ni RAAS. Okay? So particularly, we have those drugs, okay, that inhibit. Dito na papasok ngayon si ACE, no? Meron tayong mga drugs that inhibits ACE. Okay? Kung titingnan natin yung pathway, if papasok na ngayon yung drug, yung gamot na blocker of the enzyme ACE, okay? Do you think mabubuo pa rin si angiotensin 2 kapag block na ngayon yung ACE? Yes or no? No, very good. Therefore, mananatiling angiotensin 1, no? Si angiotensin dyan. Okay, mananatili siyang inactive. Mananatili siyang no physiological effect. Kasi block si ACE, walang ACE. Okay? So the pathway will not push through. Okay? It will not proceed. Okay? Kapag block yung ACE. So that's a good thing about ACE inhibitor. Okay? Hindi mabubuo ngayon yung angiotensin 2. Therefore, walang increase in blood pressure. Okay? Walang increase ultimately sa blood pressure with ACE inhibitor. So antihypertensive, si ACE inhibitor. Okay? Tignan ngayon yung pathway on the right. Okay? On the right, ha? When we block ACE, okay, when we block ACE, okay, walang kinase. Walang kinase available in the action. Therefore, kung walang kinase, walang magde-degrade kay bradykinin. No? Walang magde-degrade kay bradykinin. It will not be inactivated. Kaya yung level ng bradykinin will be retained. No? Retained lang yung level ni bradykinin. Available pa rin siya, causing vasodilation. Okay? So nakuha yung action ni ACE inhibitor. Upon targeting the ACE sa RAAS, baba yung BP. On the right side nga pathway, upon blocking ACE, meron pang additional pa na vasodilation effect. Kasi nga, nare-retain niya yung bradykinin level. That's why we can say here nga, yung ACE inhibitor, it has a dual, no? It has a dual hypotensive activity. Okay, dual hypotensive action or activity. Wherein, ulit, yung hypotensive activity niya, it results from inhibitory action sa RAAS, inhibited yung RAAS with ACE inhibitor, and then stimulating activity niya to bradykinin. Meron siyang stimulating activity with bradykinin. Okay? So please take note of this activity, action of ACE inhibitor. And then we also have the second group, no, yung angiotensin receptor blocker. So asa man dito yung angiotensin receptor blocker? So andito. Ayan. So halimbawa, we have here the ARBs. Okay? Sorry. Ay, naghang na, no? Okay. So ayan. I repeat, for the second class of angiotensin blockers, we have the angiotensin receptor blockers. So itong group naman specifically, they block angiotensin 2 type 1 receptor. So take note, yung ARBs dyan, presence of ARBs, naghang na siya. Tira ha? Okay. So I repeat, presence of ARBs, okay, it blocks the angiotensin type 1 receptor. Okay, therefore, kapag na-block yung AT1 receptor dyan, di ba, may naka-block kay receptor, biskan dami pa masyado yung angiotensin 2, biskan pila pa nakadaghan angiotensin 2 ang available kung block ang receptor, kung asa siya mag-bind, useless ra gihapon ng angiotensin 2. It will not produce its desired effect kasi nga may naka-block sa iyahang agtuan, no, sa iyahang site of action, yung mismong receptor of interest niya. Kaya, kung hindi makakabind yung angiotensin 2 sa AT1 receptor, wala ding effect yan, no? Bababa yung blood pressure. Okay, walang increase sa BP na mangyayari. Okay, so these are the two general classes, no, of angiotensin modifiers. Okay, we have the ACE inhibitors, and then we have the angiotensin 2 receptor blockers. Okay. Now, okay. Now, with regards to ACE inhibitors, take note, ang ginagawa ni ACE inhibitors, para dili mo maglibog ha, basing ang inyuhang huna-hunaan parihara sila og mechanism. Magkaiba yung mechanism of action ng ACE tsaka ARBs. Ang ACE inhibitors, kanina, sabi ko, pinipigilan niya yung formation ng angiotensin 2. Pigil formation ni angiotensin 2 via inhibiting the ACE. But for ARBs, for ARBs, presence of ARBs, na-erase na siya, na ay angiotensin 2. Na-form si angiotensin 2. Nabuo si angiotensin 2. Yung ginagawa niya lang is pipigilan niya yung pag-bind sa receptor. Okay? Pipigilan niya yung pag-bind niya sa receptor. So still, no effect. No effect will happen. No vasoconstriction, no induced formation of aldosterone, etc., etc. Okay? Now question, comparing to ACE, if you try to compare ACE inhibitors, okay, versus that of ARBs, okay, which do you think has greater vasodilating activity based on the MOA that was presented? ACE, that is an enzyme. ACE is an enzyme, ha? It's the ACE inhibitor. Okay? ACE inhibitor. Okay, very good. Okay? So, greater yung vasodilating activity, okay, of ACE inhibitor. Okay, compared to ARB. So, that is based on the mechanism of action presented. So, ulitin lang natin. Diba? Sabi ko kanina, ACE inhibitor, aside from its inhibiting action towards RAAS, it also stimulates the action of bradykinin. O ano ba yung bradykinin? Ginagawa ni bradykinin is vasodilation din. vasodilation din. So, with ACE inhibitor, enhance kumbaga yung vasodilating activity niya. Okay, upon retaining the level of bradykinin. Another thing that you have to take note about ACE inhibitor, no? Please take note na yung efficacy ng ACE inhibitor, yung efficacy niya, it can be reduced, okay, in the presence of NSAIDs, can be reduced in the presence of NSAIDs. So, kumbaga, you have to take note this drug interaction, drug-to-drug interaction. Yung mga ACE inhibitors, okay, dapat must be taken in caution with NSAIDs. Kasi 'di ba, NSAIDs, ano ba yung MOA nila? MOA ng NSAIDs, they inhibit COX. They inhibit COX. Therefore, kung walang COX, walang prostaglandin synthesis. Okay, walang prostaglandin synthesis. Parang napipigilan niya yung formation ng prostaglandin. Yan yung NSAIDs. Okay? Recalling the MOA of ACE inhibitors, 'di ba, yung isa sa vasodilating activity ng ACE inhibitor, that is being influenced by the action of bradykinin, which induces prostaglandin synthesis. 'Di ba, naalala, yung bradykinin, the reason merong vasodilating activity siya because of prostaglandin synthesis. Now, with NSAIDs, pinipigilan ni NSAID yung synthesis ng prostaglandin. So, somehow, it reduces the activity of ACE inhibitor, ultimately, with NSAIDs. Okay, so if ACE inhibitor is concomitantly taken with NSAIDs, prostaglandin synthesis will be inhibited. So, reduced, kumbaga, yung vasodilating efficacy or activity ng ACE inhibitor. So please take note of this drug interaction. Okay. Next, we also have other drugs, no, na naka-highlight di are. 'Di ba? Yung nasa taas, ito muna. Yung spironolactone, naalala? 'Di ba, na-mention ni siya, spironolactone, eplerenone sa potassium-sparing diuretics. Recall, under potassium-sparing diuretics, there are two classifications. Ang spironolactone, eplerenone, they are under aldosterone antagonist. Aldosterone antagonist. That's why andyan sila. They also target somehow a portion of RAAS, particularly on the aldosterone part. Okay? Pinipigilan niya yung active binding ng aldosterone to its receptor. Okay, spironolactone, eplerenone. And then we also have aliskirin sa taas. Ayan. So, i-erase ninyo. I-erase ninyo ng X. Okay. Ayan. Nagalag na. I-erase the X1. Okay, kaya basing maglibog mo ba, ang inyong pag-study, ginablock ang drug. Diba, gi-X na ko na siya ganina kay para di mo maglibog sa normal nga pathway of RAAS. Okay? Then, karon pa na ko gi-insert si drugs. Okay? So, with the presence of aliskirin, take note, it inhibits renin. Okay? Ito yung ini-inhibit niya. Kaya minus to renin. So, inhibited si renin with aliskirin. So, renin inhibitor lang po si aliskirin. Okay? Sige. Next. So ito, na-discuss na ito, no, yung MOA, yung mechanism action ng ACE inhibitors. Again, it inhibits the converting enzyme ACE, or please take note, another name of ACE, okay? This is a peptidyl type, no, nga dipeptidase enzyme. Okay, or this is also known as kinase 2. Aside from that, it activates bradykinin. Okay, so na-discuss na itong nasa slide na dito. Now, with regards to the specific examples of ACE inhibitors, madali lang po ma-identify, okay, yung mga ACE inhibitors, those ending in pril. Okay, halimbawa, captopril, fosinopril, enalapril, lisinopril, perindopril, ending in pril. All are ACE inhibitors. Now, you have to take note under specific examples of angiotensin enzyme inhibitors that all of them are prodrugs. All are prodrugs. So no problem no with the word prodrugs. Okay? Please take note na may exception. Okay? Merong tatlong ACE inhibitors na drugs na already active. Okay? They're already active. And these are the captopril, enalaprilat, and lisinopril. So yung palatandaan ko dito is I simply write still the word ACE inhibitor. Okay, di ba? ACE, that is how I write it. ACE, then I. But uh, just take note this straight line as letter L. Okay, para for lisinopril. Okay, mnemonics lang yan. Okay, active na po yung captopril, enalaprilat, and lisinopril. The rest, prodrugs. When you say prodrugs, they are still inactive. They have to undergo metabolism pa in the body to form its active form. Okay, next. For angiotensin receptor blockers naman, those ending in sartan. Okay? So, madali lang din sila ma-identify, ending in sartan. Mga angiotensin 2 receptor blockers. Okay, so no problem with their MOA. Okay, based on the name itself, no, or the term, okay, of the class of drug itself, it blocks the receptor angiotensin 2, particularly the type 1 angiotensin 2 receptor. Okay, so halimbawa, losartan, this is available in the market as Cozar, okay, or Cozar. Then, yung valsartan, yung Diovan. Yung Micardis, ito yung common no, sa ARBs. Micardis, telmisartan. Okay, brands, no, brands. Now, when it comes to antihypertensive effect, please take note na walang ga-dominate between ACE inhibitor and ARBs. Okay? If we try to compare their effectivity as antihypertensives, equal lang po yung antihypertensive effect nila. Doon lang sila nagkakaiba sa vasodilating effect. Pero with as an antihypertensive, they are equally effective kasi parehas lang sila ng end result, 'di ba? Yung end result generally ng ARBs tsaka ACE inhibitors, they inhibit the angiotensin's action. Okay, they inhibit the angiotensin's action and that is via lowering no the BP. Okay, so please take note ha. Please do not be confused with the vasodilating mechanism of action nila or property. Iba naman yun. Okay? Ibang usapan naman yun. Pag vasodilating yung tinanong na activity, greater talaga yung kay ACE inhibitor. But as an antihypertensive, okay, in general, equal lang sila. Okay? Now, for the clinical uses of ACE inhibitors and ARBs, please take note, first line sila in the management of hypertension. Diba tatlo yung first line that was recognized by AHA? Meron tayong itong dalawa, ACE inhibitors and ARBs, yung thiazides, tsaka CCBs. Okay? So, first line, take note, first line sila, among Asians. Okay? Among Asians. Kaya may nakalagay, non-African Americans. Okay? May na-mention ako, di ba, sa vasodilator nga first line for hypertension for African American combination. Okay, ito, yung ACE inhibitors or ARBs, sila naman yung first line for hypertension management. Okay? So among Filipinos, halimbawa. Okay? As long as Asians. Okay, below 60 years old. And also first line in the management of hypertension with diabetes mellitus. Katong pasyente na may high blood plus may diabetes, the one that is being prescribed to them is either ACE inhibitor or ARBs. Also, this is a backbone treatment for congestive heart failure. Okay? Usually, gina-combine siya, okay, with Pag sinabing backbone treatment, combination, no? Combination drug siya kumbaga. Okay, for the management of heart failure. Particularly, it is being combined with beta blockers. Okay, beta, excuse me, blockers. Okay. And then first line in the management of proteinuria. When you say proteinuria, mataas protein sa ihi. Okay, protein in the urine. Okay, proteinuria. Kasi when you say uh, there is already presence of protein in the urine, that is an indicator nga that person already has a kidney disease. Okay? Kumbaga, indicator yan nga may damage sa kidney niya. Kasi dapat ang isang healthy nga kidney, it won't let a protein, particularly the albumin, okay, to pass through the urine. Okay? Hindi po yan healthy no kapag may presence of albumin sa urine nyo. Okay, so the first line in the management of proteinuria po is ACE inhibitors or ARBs. Okay, then regarding the adverse effects being shared by ACE inhibitors, ARBs, so this is just based on their mechanism of action. So of course, it causes hypotension. And please take note, they causes hyperkalemia. Hyperkalemia. Okay. Oh, question. If yung tao is taking ACE inhibitor, example captopril, is it okay na it is being combined with a spironolactone nga drug? Is it okay based on this adverse effect? Do you think it would be fine? No. Okay, very good. No, kasi 'di ba, if you recall, spironolactone, what is this type of diuretic? Spironolactone. 'Di ba? This is okay, very good. It is a aldosterone antagonist, very good. Potassium sparing in general. Potassium sparing diuretic, meaning very distinct sa mga potassium sparing diuretic na nagkukos sila ng hyperkalemia. 'Di ba? Nagkukos sila ng hyperkalemia. Kaya, hindi sila kino-combine with the antihypertensive ACE inhibitors or ARBs kasi nagkukos din sila ng hyperkalemia. So it might worsen, no, the hyperkalemic condition. And then regarding the toxic effects, specific lang po kay ACE inhibitor, very common yung cough. Very common yung cough. Okay, normal lang na. Normal kaayo nga ang if ang pasyente or ang tao may maintenance drug na captopril, halimbawa, isang ACE inhibitor, naagi ka ng usual nga dry cough. Okay? Yung reason dyan kasi yung mediator that specifically play a role sa development ng cough for a patient taking ACE inhibitor is because of bradykinin. Okay? 'Di ba yung ginagawa ni ACE inhibitor is gina-inhibit po niya ang degradation ni bradykinin. So merong bradykinin. Now, upon inhibition of the degradation ng bradykinin, meaning to say, kapag may elevated level ngayon ng bradykinin usually accumulates in the lungs. Okay? They usually accumulates in the lungs. Okay? So, normal nga side effect yung coughing. That is a very normal side effect. Kapag na-accumulate yung bradykinin sa lungs, there would be a coughing side effect. Okay, idiosyncratic meaning hindi siya immune related. Okay, non-immune related. Okay? So that's idiosyncratic. Also, angioedema is very common. So please take note of this, angioedema. It also happens among ACE inhibitors. Then for ARBs, specific to losartan, meron siyang toxic effect na hyperuricemia. O kapag hyperuricemia yung adverse effect, saan siya contraindicated na patient? Patients with contraindicated to patients with, very good, patients with gout. Okay? So para maiwasan yung severe or worsen nga hyperuricemia, iwasan no, iwasan nila yung losartan. Okay, yung combination drug with losartan. And then for special class ng agent, special class of agent that also targets RAAS is yun na nga, na-mention kanina, aliskiren. Okay, aliskiren. So I've mentioned that it is an inhibitor of renin. Okay? Kumbaga, it specifically inhibits the binding of renin to the protein site of angiotensinogen. Di ba, yung substrate kay si angiotensinogen. Once renin reacts to angiotensinogen, dyan nabubuo si angiotensin 1. Pero yung ginagawa ni aliskiren, pinipigilan niya yung active binding ni renin sa protein site of angiotensinogen. Okay? So, all in all, kapag pigil ito, wala na din ito. No? Yung mga nasa baba, wala na rin. Okay? Now, please take note that with aliskiren, this is usually given in combination with ACE inhibitors. Okay, usually given with ACE inhibitors. Okay, for the management of hypertension. Kasi hindi siya ganoon ka effective no nga antihypertensive via just blocking renin kasi there are other triggers, 'di ba, that could release or cause the release of renin. So pwedeng na-inhibit niya si renin, pero there are other factors that triggers beta 1 activation, that triggers renal hypoperfusion. Pag may mga ganun, may renin ulit. 'Di ba? May renin ulit. So it would be good if it is combined with ACE inhibitor, yung aliskiren. Okay? Ayan. And then for its toxic effects being seen with aliskiren, the same lang din with ACE inhibitor. So it produced the same toxic effect, okay, with ACE inhibitors. So ano yung mga toxic effect ng ACE inhibitor? Okay, yung angioedema, syempre, wag na yung lungs. Okay, wala naman siyang effect kay ACE, 'di ba? Si renin inhibitor, si aliskiren. Hindi naman ACE yung tina-target niya. So yung toxic effect being seen with aliskiren is yung angioedema, halimbawa hyperkalemia also. Okay, susulat ko ha. Toxic effect ng aliskiren. Okay, which is also seen among ACE inhibitor is hyperkalemia and then angioedema.